Bertrand, any other thoughts on this
Yeah.
on this space with kind of early
I mean,
localized
that's
disease?
that's a space we urologists we know very well. We've been giving hormone for 20 years, and there is a subgroup of patients we don't pay enough attention. These are the patients who had previous cardiovascular history. So those who had experienced myocardial infarction, they have a stent, they had a stroke, and I would say within 2 years, there's a whole lot of information about these patients, and several observations have to be made. The first one is if you don't take care, you can have up to 1 patient out of 3 that's going to present a new cardiovascular event. It's been confirmed with AbbVie and as well. So you shouldn't treat this patient the same way. From the basic science point, we have learned a lot that cardiomyocyte, lymphocyte in the heart do express FSH receptor, androgen receptor, GnRH receptor, and there's a whole world of exploration around the benefit of GnRH antagonist. In Journal of Urology a few weeks ago, there was a beautiful paper by a guy named David Margel in Israel who showed that actually if you treat patient with previous cardiovascular disease, randomized agonist, antagonist, you've got like 16 times more cardiovascular even with the agonist. And the fact that you see much less with the antagonist, this is probably linked to direct activation of GnRH receptor and FSH. And on top of that is coming with initial information about the value of pro-NT-BNP as a marker, probably in a few years, point of care marker to identify patients at very high risk of cardiovascular disease. So we know that the big problem with the big trial is that they incorporate very healthy patients. This is not the typical prostate cancer. So really the message, if your patient is on Plavix or something like this, please be careful. You may actually have no benefit from your treatment because you're going to induce further cardiovascular disease. So I believe it's very important.
I think this is a really important theme, and it's one of the concerns we have about curing patients is that it comes at a cost.
Yeah.
And these are the costs that we do need to discuss. And it brings up the point of, do we need to cure patients? Are there patients that we can do active surveillance on with early prostate cancer? What do those patients look like? What's the data supporting
Well,
that?
I would actually counter and pick up on what Bertrand said and ask the question of how confident are we that the duration of ADT, for example, that we give in response to in combination with radiation is the optimal duration for that patient. As Bertrand said, studies are fit patients in general, have a proscribed period of time, and then we say that's the duration that you need. And it could be that patients with cardiovascular risk may benefit from a shorter duration of ADT, as that would be sort of the sweet spot where they get the benefits of the ADT but not the risks of it. So there's a lot more work to be done. It's such a, hormone therapy is in many ways such a basic thing, but yet it's also so complex, and it's gets us back to our roots in internal medicine, in fact. And so a lot more studies that need to be done.
It's really the art of medicine, isn't it? It's really taking this clinical data, prescribed data, and putting it into the real world, in the real practice.
And so for high-risk patients, I will think about those risks and the competing risks for the patient. And what I typically will say is, for example, if the data supports 2 years of ADT, for example, I'll say, well, let's begin it, and this is what the data say, but let's renegotiate after a year, where if a patient's doing exquisitely well from a cancer control perspective, but having side effects that they don't like, then we have a conversation.